Welcome to our discussion on ceftriaxone for methicillin-susceptible Staphylococcus aureus bloodstream infections. We'll explore its association with increased short-term mortality based on a systematic review and meta-analysis by Maraiolo, Nobile, and Gentile, published in the Annals of Medicine. Staphylococcus aureus bloodstream infections are significant in clinical medicine, with global incidence between 9.3 to 65 cases per 100,000 annually. Mortality rates are high, with 30-day mortality at 20% and 90-day at 27%. For methicillin-susceptible Staphylococcus aureus, standard care includes antistaphylococcal penicillins and cefazolin. Ceftriaxone offers once-daily dosing, but its efficacy is debated. Ceftriaxone offers once-daily dosing, simplifying administration compared to nafcillin, oxacillin, and cefazolin. It's outpatient parenteral antimicrobial therapy friendly, requiring no renal adjustment. However, high protein binding limits free drug availability, and standard dosing may only achieve bacteriostasis in methicillin-susceptible Staphylococcus aureus strains. The European Committee on Antimicrobial Susceptibility Testing classifies methicillin-susceptible Staphylococcus aureus as susceptible, increased exposure. This meta-analysis adhered to PRISMA 2020 guidelines and was pre-registered in Prospero. We searched PubMed, Embase, and Scopus up to December 31, 2025. The study focused on adult patients with methicillin-susceptible Staphylococcus aureus bloodstream infection, comparing ceftriaxone to antistaphylococcal penicillins, or cefazolin. Outcomes included mortality, clinical success, and safety. Statistical methods involved random effects models and meta-regression. The 11 studies included were observational cohorts, primarily retrospective, with one prospective. They spanned the United States, Israel, and the Netherlands. Ceftriaxone was consistently dosed at 2 grams daily. 5 studies were in outpatient parenteral antimicrobial therapy settings. Newcastle-Ottawa scale scores varied, with most studies scoring between 5 and 7, indicating moderate to high quality. The primary outcome, 30-day mortality, shows a pooled odds ratio of 3.33, indicating higher mortality with ceftriaxone. Empiric use significantly increases mortality, odds ratio 3.76, while definitive use shows no significant difference. For 90-day mortality, a non-significant trend suggests higher mortality with ceftriaxone. Clinical success trends lower with ceftriaxone, but lacks statistical significance. Secondary outcomes showed no statistical significance. Attributable mortality had an odds ratio of 2.54, persistent bloodstream infection 1.06, and microbiological clearance 0.97. A borderline trend favored ceftriaxone for 90-day readmissions, odds ratio 0.81. And a approximately 2-day reduction in length of stay was noted, but neither was significant. Ceftriaxone's high protein binding limits its free drug fraction, impacting its antimicrobial efficacy. For beta-lactams, maintaining free drug time above the minimum inhibitory concentration is crucial. Methicillin-susceptible Staphylococcus aureus's minimum inhibitory concentration values necessitate higher exposure for bactericidal effects. Studies show standard dosing often fails, with high-dose regimens recommended for effective treatment. Alsawaida et al. Found no significant efficacy difference between ceftriaxone and standard care, concluding ceftriaxone as viable in acute care, excluding endocarditis. Yetmar et al. Noted no mortality difference but lower toxicity with ceftriaxone. Our findings differ due to stricter criteria, a larger evidence base, and stratification by antibiotic timing. Clinicians managing methicillin-susceptible Staphylococcus aureus bloodstream infection should consider alternatives to ceftriaxone. Early oral switch options include cotrimoxazole and clindamycin, as demonstrated in the Staphylococcus aureus Bacteremia antibiotic treatment options randomized controlled trial. Long-acting lipoglycopeptides like dalbavancin and auridavancin offer outpatient parenteral antimicrobial therapy solutions. Daptomycin is a cost-effective outpatient parenteral antimicrobial therapy alternative, though its safety profile is less favorable than beta-lactams. Ceftriaxone is not recommended as routine initial therapy for methicillin-susceptible Staphylococcus aureus bloodstream infection due to higher mortality risk. Prompt de-escalation to ceftriaxone or antistaphylococcal penicillin is advised. Consider ceftriaxone only in low-risk outpatient parenteral antimicrobial therapy patients after blood culture clearance and specialist consultation, ensuring robust follow-up and source control. Higher dose regimens may be considered, despite limited outcome data. Ceftriaxone at standard dosing is linked to higher 30-day mortality compared to standard of care. Empiric use is particularly risky. The harm may stem from suboptimal dosing. Future research should explore high-dose regimens. Routine use for methicillin-susceptible Staphylococcus aureus bloodstream infection is not advised. De-escalation to ceftriaxone or antistaphylococcal penicillin is recommended.